Why do parathyroid surgeries fail? I'm Dr. Babak Larian from Center for Advanced Parathyroid Surgery. Parathyroid surgeries unfortunately fail at times. It is a disaster. It is horrible. It's horrible for the person who had the surgery. It's horrible for the surgeon who's doing the surgery. We all obviously have the same end result in mind. And when things fail, it really breaks everyone's heart. The person, of course, more so than anyone else. But there are reasons for it. And I think that one of the most important things is for you to have a very good relationship and faith and trust with your physician, with your surgeon, so that when a failure occurs, you understand why it has occurred, because that surgeon probably is the best person to do the revision surgery if they understand the disease well. So pick your surgeon well from the beginning, from the get-go. You need to be with someone you have full faith and trust in, and they are responding to you appropriately, and you have a good rapport with them. But let's go through and look at why. So before we start, let's talk about what the parathyroids do briefly. Parathyroids are in charge of controlling the level of calcium in your bloodstream, all right? So they look at the level of calcium. If your calcium goes lower than expected, they produce parathyroid hormone, right? And parathyroid hormone, as you see here, goes to your bones and tells your bones to release calcium. And by doing that, the calcium level goes up and your PTH will come down. So that relationship is inverse, right? They also go to your kidneys, tell your kidneys to reabsorb the calcium back from the urine. Don't let it go so easily. They activate 1-alpha hydroxylase, which is an enzyme in the kidney that transforms inactive form of vitamin D to the active form. And that active form goes to your intestines and increases the absorption of calcium from 20% to a massive 80%. So vitamin D is essential in this process. And all of these systems have a feedback loop. The system breaks down when there is abnormalities. Now, the abnormalities could present as a single tumor, a single adenoma, multiple adenomas, in this case 2, that happens only 10% of times, and hyperplasia, which means every single cell in every single parathyroid gland is abnormal, right? That fortunately happens very infrequently at 5%. And cancers, which are exceedingly rare, fortunately very, very rare. In the past 20 years, I've seen a handful of cancers, fortunately, parathyroid cancers in specific. They are just not a common enough phenomenon, fortunately. What is the difference between adenoma and hyperplasia? Well, adenoma is when a single cell in a single gland becomes abnormal, turns into a tumor. The tumor starts duplicating and taking over the system. It produces a lot of PTH, and that excess PTH causes your calcium level to go higher than what your body wants. In the process, the normal parathyroids that are not working shrivel up and get smaller, and that's what makes sometimes doing parathyroid surgery challenging, because the normal parathyroids will be smaller and hard to find. In case of hyperplasia, all of the cells in all of the glands become overexcited. There are changes potentially genetically that cause it, and they all perform abnormally. They produce a lot of PTH and cause the calcium levels to generally rise up. This is a slower process, but more indolent, but more deeply impactful because it's a longer process. And so the treatment for an adenoma is to just remove the adenoma. Remove the adenoma here, take it out, leave the other 3 glands intact so that they can function. And you can see if your parathyroid hormone level at the beginning of the surgery was 120, if you take the parathyroid out, the other 3 shriveled up glands that are working, they're not dead, they're working, but less so, they still produce a minimal amount of PTH. It takes about 3 weeks for those glands to really get to their full working potential, to their full glory, right? In case of hyperplasia, you have 4 abnormal glands, and they are all overactive. You want to take at least 3 of them out, right? And on the 4th one, you might want to make an assessment to see how much of that gland you want to leave behind, to see how it functions. And you make that decision based on your experience and your guess as to how big a size of a normal gland would be for this person. and you check your PTH at the end of the procedure. If you start at an 85, you end up at 17, the lower limit of normal, something along those lines, then you know that you have an adequately functioning parathyroid remaining. Surgery is successful, you're done. So these are the successful cases. So before starting to talk about what failures occur and how, let's talk about the anatomy. This is the thyroid gland, which sits right on top of the breathing tube, which leads to the voice box and the Adam's apple right there, right? The parathyroid glands lie usually behind the thyroid in these locations. Now let's take a deeper, more zoomed in look at it. You can see the thyroid again here. Let's do it in blue. This is the thyroid sitting on top of this white breathing tube, the trachea. You can see the vocal cord nerves. I'll draw them in green right there, going behind the thyroid to go into the voice box, right? And then you can see the 4 parathyroids. Interestingly, the lower parathyroids are usually superficial to the nerve. So this is the nerve. And the upper parathyroids are deep to the nerve, right? So the level of the nerve and the parathyroids are very important. That can tell you which parathyroid you're addressing, right? Now, 80% of the time, the parathyroids are exactly in these locations, right behind the thyroid, but 20% of the time, they're not. And the reason for that is that parathyroid, interestingly, develop from pouches in the throat in the 6th week of life when you are in your mama's belly, right? And that's where it all starts, at the 6th week. And these little pockets that form in the throat, the first pocket, let's do that in black here, makes the ear. The second pocket makes your tonsils in your throat. The third pocket, which is just underneath that, makes your lower parathyroid and the thymus gland, right? And they migrate down. And the fourth pocket makes the upper parathyroid. So interestingly, the lower pocket makes the upper parathyroid, the upper pocket makes the lower parathyroid. The upper pocket has a mixture of parathyroid tissue and thymic tissue, right? So what does that mean? Is that sometimes when the third pocket is migrating down, the parathyroid gets trapped inside the thymus and is not actually next to the thyroid, right? Sometimes that parathyroid actually overshoots and goes all the way down into the chest. Sometimes 2 parathyroids, as they're moving along, fuse, and this person has 1, 2, 3 parathyroids, one on both sides. So 3% of the population have only 3 parathyroids. Sometimes, as the parathyroid is migrating down, it leaves pieces behind, right? It's not very clean about its migration. So this particular person has 1, 2, 3, 4, 5 parathyroids. Anywhere between 3 to 20% of people have more than 4 parathyroids, right? Which can be problematic sometimes during surgery. That's, again, the experience of your surgeon counts a lot. Because the location of these parathyroid can be inconsistent, we try to do what we call localization scans, right? These are the studies to try to tell us where the parathyroid is so that we can minimize our approach. So if we can find the parathyroid is right there, when we do the surgery, we only go there to look for it. We don't look all the way around in the neck to find the abnormal gland. And there are four studies that are available today that are fairly good. The ultrasound, which is actually my favorite, especially when done by your surgeon in the office. The surgeons have the advantage over the radiologists of doing an ultrasound, and then when they do surgery, compare what they saw to what is actually live in the person's neck. And that's a huge advantage, I feel, right? There's the Sesame B scan, which is the scan that was preferably used 10, 15 years ago by everyone, and now its role is becoming more limited, right? Because it's not as good a study. There's the 4D parathyroid CT scan, which is also a very good scan. And then lastly, the choline PET scan, which is in the US only available as a research tool in several facilities, not commonly available, right? But I'll show you some examples of when I was able to use it and help people. But let's look at ultrasound. Ultrasound can be extremely good. You can see in this image that the ultrasound is showing the thyroid gland very well, and then the parathyroid underneath it. And you can see the shape of the parathyroid completely shows this to be the same as the shape of the tumor when removed. This is after I removed the tumor in surgery. And this one the same. You can see the shape correlates very well. But more importantly, it tells you the relationship of the parathyroid to the thyroid gland. It tells you where the blood vessels are coming in that are feeding it. You can see the blood vessel here feeding this particular parathyroid. What's next to it, how deep it is. This is the distance from the skin to the level of the parathyroid. So you know as a surgeon how much work you have to do to get to that parathyroid. But additionally, you can also not only see the parathyroid, but you can see nodules in the thyroid gland, and you can decide if you need to address those nodules at the same time. The sestamibi scan. This is a nuclear scan where a patient is injected with the material and 2 scans are taken. The first scan shows a lot of things lighting up: the thyroid gland, the salivary glands, heart, liver here, all the salivary glands here. And then when you do a delay scan, the thyroid somewhat fades away and the parathyroid still remains. But as you can see, this is a subtle scan. You're looking for subtle findings in there. It's not very obvious, right? So we try to make this a better scan by combining it with a CT scan, and we call it a SPECT CT, where you superimpose the CT scan on the activity or the dark spots that you saw in the sestamibi. In this particular case, that picture is transformed to orange coloration rather than black, and you superimpose it, and here you go, you see some activity, and you can have some relative anatomy. But you saw that on ultrasound you got a more detailed anatomy, so this is not superior to it, unfortunately. It is a scan. I use it sometimes, but on rare occasions. And this scan is not so reliable when the PTHs are less than 100, right? When it's over 150, the accuracy of the scan is about 84.5%, right? So at its best, it's 84% accurate. When the PTH is low, it's only 50% accurate, right? The 4D parathyroid CT scan. This is not a special CT machine. This is just a special protocol on any machine, right? It can be done anywhere as long as your radiologist has a little bit of experience about how to do it right. And it can show you the parathyroid very well. The parathyroid is here on the image without contrast. When you give the contrast, it really lights up. After the 30 to 60 seconds later, when you look at it again, the contrast stays in the thyroid here, but leaves the parathyroid, right? And that's how you can distinguish between thyroid tissue and parathyroid tissue. Lymph nodes, this is potentially a lymph node here, right? And it's not really lighting up. So you can distinguish between parathyroid, thyroid, lymph node, and so on. I like the scan as a backup when the ultrasound is not so much, and it gives you a lot more detail and relative relationship to other structures and even the blood vessels that are feeding that. MRI, why can't we use MRIs? MRIs are fantastic, just not for parathyroid, because the distance between each cut of an MRI is 3 millimeters. The distance between each cut of a CT scan is 1 millimeter. So if you have a parathyroid here, with a CT scan, you have so many cuts going through it, it'll catch it. But with an MRI, your cuts may actually miss it or just get a little tip of it. It's not visible enough to be diagnostic or to give you confidence that you got it, right? Okay, so again, with parathyroid adenomas, you're trying to find the adenoma alone and remove it and not disturb the normal glands. With hyperplasia, you're trying to find all of the glands, remove the largest ones, leave the smallest one. The reason you want to leave the smallest one is because it has the slowest growth rate and probably the slowest production of PTH. So by leaving that last one, you have bought that person a longer period of time before that particular parathyroid gland can grow, get bigger, and get them into trouble. Hopefully you've bought them a lifetime of that, right? So during surgery, what we're doing is we check PTHs. Let's go back to the previous screen. We check the PTH at the beginning of the surgery, right? We do what we need to do. In adenoma, just remove the adenoma. In hyperplasia, remove 3 glands or 3 1/4 glands, 3 1/2 glands, right? And then check PTHs again. And if the PTH comes down appropriately into the normal range and stabilizes in that level, you know that you've removed the abnormal gland. The remaining glands are not over-functional and they're functioning adequately for the person to be okay in terms of parathyroid function, right? There's a lot of information inherent in the PTH testing right there that's valuable to you. So how can PTH testing fail you? Well, if you have one large adenoma producing a lot of PTH, right? This thing is producing a lot of PTH. And then you have a microscopic adenoma that is producing very minimal amount of PTH, an amount that's not comparable. So the large tumor may be producing 180 units of PTH, while that little one is producing 2 or 3 units of PTH, right? So the difference between this number without that microscopic would be 45 versus 47, right? So it's not detectable. That's one scenario. So these are the patients that I do surgery on, and successful PTH comes down, 6 months, a year later, their PTH starts rising up again. And that's why I do repeat testing to catch these patients that are going through this, to catch them earlier before it impacts them deeply, right? Or the most likely scenario that I have seen, that I've experienced, is that you have an adenoma on a background of hyperplasia. So when you take the sound, the PTH does go down, the calcium does go down, but it starts creeping up because the other 3 glands are overworking, right? They just weren't as powerful as the adenoma was, right? And as big. And so whenever you need a revision surgery, your surgeon needs to keep that in mind, that that possibility exists, right? And that's a hard one because it requires that they go in and find all the glands and then make an assessment, all right? Again, the experience of your surgeon really, really, really matters, okay? All right, let's go on. So let's look at some revision cases. Gary Shandling, unfortunately, had hyperparathyroidism and had heart issues subsequently. And hyperparathyroidism does cause heart issues. So I wish he had addressed that because he was a good guy. Anyways, revision parathyroidectomy. This is not Gary Shandling. This is another patient I had, a 46-year-old science teacher with symptomatic hyperparathyroidism, bone pain, brain fog, and bone loss. Had a surgery by a very experienced surgeon, and during that surgery, before that surgery, he had a sestamibi scan that was negative, an ultrasound which showed right lower activity. The right upper was identified and biopsied, the left and right lower removed. So these 2 were removed. Let me do it in black. These 2 were removed, right? And the right upper one was identified and biopsied. The left upper was not found, right? PTH never came down. Patient continued to have symptoms and felt as he had been. He said he didn't even feel better temporarily, which tells me that this parathyroid was never touched, because if you at least were close to it, you can put it in a state of shock and temporarily the PTH comes down and then it comes up again within a couple of weeks, right? That at least tells you at least the surgeon was close to it, right? Calcium and PTH continued to stay high. I did ultrasound, a 4D CT scan, and a sestamibi scan. So this is an area where I would do a sestamibi scan just because everything else. I did an ultrasound and a 4D, it didn't show it. I did a sestamibi, it didn't show it, right? So then I had him do a choline PET scan. I actually sent him to UC San Francisco to do the scan, and this is what the scan showed. So this is cross sections like this. We're at the neck level, thyroid is active there, and then when we come into the chest, you're gonna see these 2 areas of activity in the chest, right? And so he had a robotic surgery. You can see the lung here on the side, and the heart is pumping deep to it. The robot is moving everything around. It's found the tissue. You can actually see the parathyroid there. It's dissecting it out. This is being done by a thoracic surgeon. This is the robots. You can see the arms of the robot working, and the two pieces were held together. They're being placed in a basket, in a sack to be removed. And during surgery, the PTH was 198. At 5, 10, and 15 minutes after removing these, it came down to 37, 27, 21. The absolute important significance of this is not only that the patient was cured of the hyperparathyroidism, but that last remaining parathyroid, the right upper parathyroid that was biopsied, is still functioning. It wasn't damaged enough or it's not working. Because if the PTH had come down from 198 to 12, 3, and 0, then I would know that that right upper did not survive the surgery, and I would have to take a portion of one of the parathyroid, the abnormal parathyroids that I removed, cut it into little pieces and insert it in the muscle in the hopes that that would function again, right? So this was a success after a failed procedure, right? And these are the fragments of the 2 fragments of parathyroid that they took out. 1 month after surgery, calcium and PTHs were much lower. And a year and a half later, the bone loss had fully recovered and the patient had good activity. Now this guy was fully engaged in taking care of himself. He was hiking regularly and was able to recover. Now the next failure is a really interesting one. It's a parapharyngeal space adenoma. This tumor is all the way up next to the throat, but deep to the jawbone, right? So this person had 3 previous surgeries. None of them showed a decrease in PTH, and one of them caused the vocal cord paralysis, the first procedure that she had, unfortunately. She had this procedure done in another country, the first 2 procedures in another country before coming to me, right? I did the 3rd procedure, and we had limitations because her vocal cord was paralyzed on one side and not the other, so her and I made a deal that I would not go on the side that had a functioning vocal cord because I didn't want to paralyze that, right? And the surgery failed. None of our scans had really shown anything. I did a comprehensive look at the site where the vocal cord nerve was paralyzed, a very cursory look at the other side, didn't find anything, PTH didn't come down. So she did a PET choline scan which showed activity up there, right? So we pursued that by doing an MRI which showed a lesion here. Let me do it in yellow. This is the frontal view of an MRI. You can see the earlobes right there, earlobe there. The jawbone is here. This is the carotid artery. Thyroid would be in this level, and this thing is between the carotid artery and the jawbone there, or the parotid gland there. This is another view of it. These are cuts in this orientation. You can see the tooth sockets, the jawbone, the blood vessel, and the parathyroid in blue. And this is the surgery. PTH at the beginning of the surgery was 125. This is the patient's neck. They're going through the neck, going all the way up. And there it is, the parathyroid. This is all the way up here. So we went through an incision here, all the way up to there. There's the parathyroid. You can see it well. You can see the carotid artery pumping right next to it. This is the nerve that goes to the tongue right above it. We have a good visual of where we need to be. This is after the tumor was removed. You can see it's missing. This is the tumor itself. And this is the nerve to the tongue. You can see the nerve to the tongue is preserved. The tumor was in the sheath, in the covering of that nerve. So I had to open the covering to take the tumor out. And once that was removed, you can see that the PTH levels came down as we had hoped, right? And again, not only did they come down and stay down, but they stayed in the normal range, telling me that one of her remaining parathyroid was functioning appropriately and that she would be fine. 1 week later, calcium and PTH in the normal range, and she's feeling better. These are some of the reasons surgeries failed. They failed because the parathyroid is not in the normal location. It could be in an abnormal locations like the 2 that I just demonstrated. It could be that the person has more than 4 parathyroids and the surgeon did not look for the 5th parathyroid. It It could be that you have a small microscopic tumor developing in another one that's not visible on any scan or PTH testing. It could be that you have mild hyperplasia and a tumor develops on the background, right? And it's oftentimes, unfortunately, the experience of the surgeon and how far they're willing to do to go in surgery to find the abnormal parathyroid and how well they understand this disease, right? So the key thing is for you to find an experienced surgeon that you trust and you have rapport with. I hope this is helpful. If you do find this helpful, please push the like button and subscribe to us. There'll be more videos that hopefully will help you in your journey.